Hi, this is Dr. Sam Wood from Gen 5 Fertility. And so today I'm going to answer those questions, but also you may learn something you didn't expect to learn. And in the future, I would love for you to let us know if there are any other questions, ones I've missed today, that you think would be of value. I will answer those questions and we'll post the answers. The question is whether fresh or frozen sperm is better for IVF. And the answer is it makes absolutely no difference because we take care of patients from around the world. Probably 70% of the time we use frozen sperm, and it works beautifully. So it's very nice because sometimes, for example, the partner may have an infection, may have a cold, may have something else that would affect the quality of the sperm. And so it's very nice to know that if you have fresh sperm frozen, in that case, it's going to be every bit as good as the fresh sperm. The question is, why is a frozen embryo transfer frequently preferred over a fresh embryo transfer? Well, there's several reasons for that, but I think the most obvious one today is that almost all patients choose to do genetic testing of their embryos before they do a transfer. And it takes up to 2 weeks to get those results back. So as you might imagine, it wouldn't be possible to do a fresh transfer if those embryos are being tested. And so today, we generally do probably 90–95% of transfers as a frozen embryo transfer. There are other advantages too. It turns out that pregnancy rates are higher if you do a frozen embryo transfer as opposed to a fresh embryo transfer. And there's some data, a little controversial, but that says that the babies may even be healthier, at least in terms of weight. So for lots of reasons, it's better to do a frozen embryo transfer rather than a fresh one. The question is, how long should patients wait between doing IVF cycles? It's actually pretty common for a couple to decide that they want to do more than one cycle. They want to freeze the eggs, or usually as embryos, and so they build them up in case they want to have more children later. And so they commonly want to know, can I do one cycle and then do the next cycle and the next cycle, month to month, or do I need to wait? Well, there's a very nice study that answered that question. It turns out that the results are exactly the same, but they're only the same if the ovaries have returned to normal. And it's very common after an IVF cycle to have a few follicles not return to normal as quickly as one would like. So because of that, I've set a policy that you should wait 1 month. It's not an easy thing to go through an IVF cycle, and I think getting a break is actually a very positive thing from a psychological standpoint. So we generally recommend wait at least 1 month before you do your next cycle. What is the thaw rate of frozen eggs versus frozen embryos? Now, this is a good question. It's not really the most important question, though. So the thaw rate, successful thaw rate for frozen eggs is essentially the same as frozen embryos, maybe a little bit lower. But that's not really the question. The question is, once an egg is thawed, how well does it fertilize? How well does it develop? How well does it grow until it gets to the blastocyst stage? Blastocysts are important because that's the stage at which they implant in the uterus. And when you look at that, you see the rate is a bit lower for frozen eggs than for frozen embryos. And one of the things that we do here, especially in our egg donation program, is we give you a choice of frozen eggs or fresh embryos or frozen embryos. And we would suggest in general that you opt for the embryos as opposed to the eggs, even though we have many, many pregnancies using frozen eggs. What are the pros and cons of doing duo-stem? Now, duo-stem, it's a very interesting type of procedure that has not been around for that long. Essentially what it means is that you do 2 egg retrievals in the same cycle. Now, why would anyone want to do 2 retrievals in the same cycle? Well, sometimes when a woman goes through stimulation, some of the follicles grow considerably faster than others. And so what you do is you do a retrieval of the larger follicles, and then you continue to stimulate the smaller follicles until they get to the right size. Then you remove those eggs. So the big pro here is that you get more eggs in that cycle than you would have if you only did one egg retrieval, and that's why patients really like it. On the other hand, it's a tough thing to go through 2 stimulations and 2 retrievals in the same cycle. And so that makes it a little more difficult, but I have to tell you, having done many duostems, the vast majority of patients would prefer to do a duostem if there are a reasonable number of eggs that have not been retrieved after the first retrieval. The question is, what diet is best to do during stimulation? Well, it's not just stimulation, it's what kind of diet should you eat in the months preceding a stimulation cycle. Usually we recommend that you start your diet roughly 3 months before you start stimulation. Now, this is still not well known what the answer is, but right now the data indicates that doing a Mediterranean diet, and you can look that up online, and there are books about it, there's menus, all kinds of things about the Mediterranean diet, may be the best diet for fertility. So that's what we recommend to patients. Now, we also see a good number of Asian patients, particularly Chinese patients, and we haven't figured it out yet. We haven't figured out if there's some way of picking out the very best of the Chinese diet. But for a typical Western diet, the Mediterranean diet seems to be best. The question is, can a patient drink alcohol during a stimulation cycle? So there's certainly several countries in the world where drinking wine or some kind of alcohol is routine at night. And in speaking to fertility specialists from those areas, they see no negative effect. We've also had some patients that choose to have a small amount of alcohol during a stimulation cycle. It's not what we recommend, but I've seen no negative effect for them. And so for certain patients that find that to be very important, we don't tell them they absolutely can't, even though we recommend that they don't drink alcohol. So the question is, how many embryos should patients bank before they start to become pregnant? Well, a lot of it depends on your age. Let's say that you're in your late 30s or 40s, then of course you're not going to get a chance to do another cycle, quite likely, or at least the egg quality won't be as good in a second or third cycle. So those women, those couples generally want to freeze more embryos than a couple that's 30, who knows they'll have other opportunities in the future in order to get additional embryos. But ultimately, I think the most important factor is, how many children do you want? If you only want one child, and we do have a good number of patients like this, then you don't need to bank that much. You simply test each embryo, you make sure it's genetically normal, you see if there are any problems with your uterus, and if not, usually 1 cycle will do it, occasionally 2 cycles. So I think it's a very good question, but it's highly individual. If you come to Gen 5, I'll talk to you about it, I'll assess your situation, and we'll give you a specific recommendation. The question is, how many eggs should a woman bank? Now, what this question refers to is women who are freezing eggs. They're not with the right partner at that time, they may never be, or they're building their career, and so it's not a good time to get pregnant. A wide variety of things could cause a woman to decide to freeze eggs. And one of the most common questions I'm asked is, how many eggs should I freeze? Well, again, there's no good answer to that because it depends on the quality of the eggs. But in general, we recommend 14 eggs. Obviously, we're going to vary that depending on the number of children you want to have. If you come in and you say, I want 6 children, then we're going to recommend, of course, that you bank more than 14 eggs. But for 1 to 2 babies, generally 14 eggs will do it. Remember, though, that these eggs are not genetically tested before they're frozen. So when they're thawed and they're fertilized and they go to the blastocyst stage, which is the stage at which they implant, then they will be biopsied. And then you'll know for sure, but you don't really know when you're freezing the eggs, whether or not what you've made are genetically normal and whether or not they will lead to a baby. And so, again, this is a highly individual decision. We'll discuss that with you when we see you. The question is, what are the lifestyle recommendations to improve egg and sperm quality? You know, essentially, it's how you live. It's the way that you live. And I think the same recommendations people would have for general health or virtually any other activity that you want to accomplish. Obviously, you want to exercise. You want to be in good shape. You don't want to be overweight. You don't want to drink to excess. You don't want to smoke. There are a wide variety of things that fall into this category. But just living a good life, living a recommended life, I think is the best way to accomplish this. Now, many of our patients are not fully healthy in the ways that I've mentioned. They still get pregnant at excellent rates, but these are things we discuss with them before they begin their cycle. The question is, how many vials of sperm should be stored before an IVF cycle? Well, of course, it depends on how many sperm are present in each vial. But in general, the lab recommends that there be 2 vials. In the vast majority of cases, that will do it. If it turns out that the sperm count is very low, that's something we'll discuss with you, and we'll change our recommendation to one that fits the number of sperm that the IVF lab will need in order to do the cycle. The question is, how long does a cycle take from the beginning of the egg retrieval cycle until the frozen embryos are thawed and placed back into you in what's called a transfer? And the answer is, it depends. But the quickest it could possibly be would be roughly 60 days, roughly 2 months, because you do pre-treatment before you start the IVF cycle, and the pre-treatment causes your eggs to all be present at the same stage and grow together in the vast majority of cases, which yields the most high-quality eggs. We then take the eggs out, we fertilize them, we grow them to the blastocyst stage, the stage at which they implant, and then we remove a few cells from each embryo and we send them off for testing. It takes 2 weeks for the test results to come back. But during those 2 weeks, we actually begin pre-treatment for the frozen embryo transfer cycle. But generally, it's roughly 6 weeks from the time of an egg retrieval until the time of the frozen embryo transfer. The question is, what is the ideal length of time after an ovarian rejuvenation cycle to complete the IVF cycle, to do the egg retrieval? Now, there's a great deal of variation in terms of how long patients wait after doing ovarian rejuvenation. Some choose, for example, to try on their own for a while, or they do intrauterine inseminations. And it doesn't seem to matter that much how long they wait, depending on the type of procedure that they did. For patients that do generation 3, which we call ultra, we've had patients do it 6 months later and show a tremendous improvement over egg retrievals that they did before that. So the exact length of time doesn't really seem to matter. Kind of by tradition, we have people wait 4 weeks, but we've certainly seen good success at 8 weeks, 12 weeks, 16 weeks, etc. So length of time is not something that you should view as a major stressor unless you do a procedure that lasts only a short period of time. The question is, how does one decide to use an egg donor? And this is a highly personal question because there are many reasons that a woman or a couple choose to use an egg donor. But in general, I've never found this to be a major issue. I think couples, a woman knows when it's time to use an egg donor. Why? Because she simply can't do it herself. Now here at Gen 5, we put a tremendous effort into helping women who have been told, you have no choice, you have to use an egg donor. We put huge effort into helping those women overcome what they've been told. They want to have a biological child. And if they're able to do it, we want to help them do it, and it's something that we do every day. But there's certainly some couples that simply can't do it. The egg quality is not good enough. And they create eggs in some cases, but the embryos are genetically abnormal. In other cases, they're simply not able to create eggs. So it's a highly personal decision, and if you ask our opinion, we will definitely give it to you. We want to make sure that in the end, you end up with the baby or babies that you wanted to begin with. But it's you that will decide when it's time to use an egg donor, not us. The question is, should a woman repeat the ovarian rejuvenation procedure if she does not see ovarian activity, if she doesn't see follicles, if she doesn't see eggs being created on ultrasound? This is a hard question. It turns out that we do sometimes repeat ovarian rejuvenation, but not that often. And the reason is it works well if it's going to work. And so if you do an ovarian rejuvenation procedure and 8, 12, 16 weeks later you see no response, you're likely not going to respond. Now we have had a few patients that responded later. So generally we follow up for roughly 6 months after an ovarian rejuvenation procedure to see if there's any response. If someone wants to repeat the ovarian rejuvenation procedure at that point, we're absolutely fine with it, even though we've rarely seen a good response to it. Now, on the other hand, we have patients who have done ovarian rejuvenation and subsequently become pregnant and had babies. And then when they come back the next time, of course, they want to do the ovarian rejuvenation procedure again. And I think that makes a lot of sense to do. And we've done that, and we've done it successfully on multiple occasions. And it's something we would definitely recommend anyone who's in that situation consider. So this is a question about additions to routine ovarian rejuvenation. And the question is, what is the added benefit of NAD to a more traditional ovarian rejuvenation? Now, NAD is part of what we call Generation 4. This is our latest generation, and I think our most effective ovarian rejuvenation generation. And I'm very excited about the potential effects of NAD. Now, NAD is a chemical, a substance that's used for anti-aging. It's actually extremely common for anyone who's interested in anti-aging to take NAD, and many people actually have infusions, IV infusions of NAD on a routine basis. And there's a lot of data to support that, particularly animal data, very impressive animal data. So our feeling is that it enhances the response, especially to Generation 3, which we call Ultra, to add NAD to it. We're gathering the data on it, and we plan on publishing a paper showing its benefits later this year. But I would definitely recommend that you consider adding NAD either to your list of supplements. We'll give you a list, but I would add NAD to that list. And I think you should definitely consider also having infusions at least monthly during the time that you're monitoring the success of the ovarian rejuvenation procedure that you selected to begin with. So the question today is, how long should you take the recommended supplements before you begin an IVF cycle? And what this question is based on is the idea that it takes roughly 3 to 4 months for an egg to develop to maturity. And so the question is, should you be taking these supplements during that entire time? Now, my experience is no. I would recommend that a woman takes it for 1 to 2 months. During much of the time that the egg is beginning to grow and develop, it's really impervious to what's around it. It's only later, once it begins to accumulate fluid, that it becomes critical to have these supplements in your blood, in your body, at the right concentrations. So our general recommendation is 1 to 2 months, take the supplements before you begin. And in giving this recommendation, we've seen many women that had remarkable improvements in their response following ovarian rejuvenation and the beginning of the supplements. You may know that here at Gen 5, our list of supplements is a precious thing to us. We put a tremendous amount of effort into picking just the right supplements for each patient. And I think it's an important part of why we've had such great success working with very challenging patients. And this is a dynamic list. So what it says today may not be exactly what it says a month or two from now, because we're constantly looking at the research out there, and when we see something that we can add to the list that has good evidence to support it, we add it to the list. So definitely get this list when you come to Gen 5, and definitely start taking these supplements, because they do seem to be very helpful for most women. So we have many patients that are very challenging, and the reason they're challenging is that their hormone levels are perimenopausal or menopausal. For example, the FSH level is very high. And this is true both for women that are nearing menopause and for women who have premature ovarian insufficiency or premature ovarian failure. And so these women are placed on medications that allow the FSH and other hormones to return to an optimal level, so their ovaries have a chance to respond and make eggs. So one of the questions that patients ask us is, how long should we take this medication? It's a little bit complicated because it depends on your age. It also depends whether or not there's a response. Because when you're dealing with patients that are perimenopausal or menopausal, it's possible that there really are no eggs left. And so once you determine that there are no eggs left based on the length of time, based on the lack of response, at that stage, of course, you would stop the medications. Now, for the vast majority of women who have POF or POI, in that case, you know there are eggs there, virtually certain there are eggs there, so you continue for a longer period of time. So the shortest period of time we've had someone become pregnant after we started medications, if they had premature ovarian failure or premature ovarian insufficiency, was 10 days. 10 days later, they were pregnant. On the other hand, we also had a couple, it took 18 months before they made an egg. And then when they made that egg, we extracted the egg, we fertilized it, we transferred, and they went on and they had a baby. So you can see that the length of time that you would take one of these medications is longer if you have POF or POI than it is if you were perimenopausal or menopausal. The question is, can a couple transfer 2 embryos? And what are the advantages and disadvantages of that? Now, many fertility centers force you to transfer only 1 embryo. I've never felt like that was fair. So if the couple is healthy, if the couple really strongly desires twins, if they have 2 high-quality embryos, it's always made sense to me to do that, and we do that now. And right now we have several sets of twins moving forward. And I'm proud that we give couples that chance. However, you have to realize there's a downside to twins. And the biggest downside is you're virtually always going to deliver early. In fact, delivering 5 weeks early is the average when it comes to twins. And if you delivered 5 weeks early, the twins would do fine, almost certainly. However, it's possible you'll deliver earlier in the 20s, in the mid-20s, even low 20s, and in that case, of course, the babies would spend a long time in the ICU. So the bottom line is, be very sure that you really want twins, and then dedicate your life to those twins when they're in the uterus, because an early delivery can be a disaster. So I would say at least 90–95% of our twins do very well, but we're aware of those risks, and we let patients know about them and give them additional information about it so they can make the decision that's right for them. So the question is, can couples have sex during pregnancy? Now, for sure, after an egg retrieval, after an embryo transfer, after an IVF, you shouldn't have sex. You shouldn't even consider it for the first 12 weeks of pregnancy. because this is not a routine pregnancy. This is a pregnancy that is actually being supported by medications that you take. And so the chance that you'll have a complication from having sex is increased. So first trimester, no. After the first trimester, it really depends on how the pregnancy is going. If your pregnancy is going fine, there are no complications, and you don't have twins, because if you have twins, no sex during the entire pregnancy, it's reasonable to have sex. You have to do it very gently, you have to do it very carefully, and in that case, things seem to go well. Now, as the pregnancy moves along, it becomes progressively more uncomfortable for the woman, and most couples stop having sex in the third trimester, or let's say at least 4 to 6 weeks before they deliver. So you have to use good judgment. Don't do anything that's risky. Don't do anything that hurts. Don't do anything that leads to bleeding after you have sex. If you do that, you can do it safely. If there are ever any problems, stop having sex and don't do it again during the pregnancy. This baby is extremely important, and everything you do for it to extend its time in the uterus is so invaluable. You're really doing this. You're committing to helping this baby have a good life by delivering on time. The question is, what is the expected amount of bleeding during the course of a pregnancy? And the second question is it normal to have bleeding or cramping after doing an embryo transfer? I'll take the second question first. It's not normal to have bleeding after an embryo transfer, not immediately. But what's interesting is having it roughly 8 to 10 days later is actually a positive sign. In fact, in 30 years, I've never had a patient have bleeding at that time after a transfer and they not be pregnant, because that's really related to implantation bleeding. So obviously you don't want to have bleeding after a transfer, but if it's a week or more later, it actually may be a positive sign. Now, in terms of how much bleeding is normal during pregnancy, the majority of women have no bleeding at all during their pregnancy. However, if you do IVF and then do a frozen embryo transfer, it's relatively common to have some spotting after the transfer once the pregnancy has begun. And I would say maybe half of women will have some spotting. So we see this routinely. It's not a scary thing. We do look into it. We make sure that everything is going fine with the pregnancy and that there's no blood in the uterus. But in general, it does not indicate that there's any problem with the pregnancy, and it doesn't lead to any problems later. The question is, how long do patients need to stay on medications after an embryo transfer? Well, it depends. It depends on what type of embryo transfer it is. There are basically two ways of doing an embryo transfer. One is a so-called natural cycle, and so these are women that ovulate regularly, and they work off of their ovulation to determine the day to do an embryo transfer. If they ovulate, they make hormones almost immediately, and these hormones help support the pregnancy. So for them, generally, we leave them on 8 weeks, 10 weeks, something like that, in terms of pregnancy, and that would be roughly 4 to 6 weeks after the embryo transfer. Now, if you're doing a cycle that is where all the medications are given externally, then you need to stay on until about 10 weeks of pregnancy. So that's 8 weeks after the embryo transfer, because if you try to stop earlier than that, it's very common to have bleeding. But at 10 weeks, we start to reduce the dose of medications that you take, and after about a week, you're completely off the medications, and you're basically a regular pregnant patient at that stage. The question is, what are side effects of vaginal progesterone? Now, vaginal progesterone is actually pretty popular because the other option is to take injections of progesterone, and they can be quite uncomfortable. But like everything else in life, there's a price to pay. And when you take vaginal progesterone, it's very common to have discharge and itching associated with that discharge. And so sometimes it's not clear if you're dealing with a yeast infection or if it's just your body's reaction to the progesterone suppositories. So that's something we look at carefully. If we think it can be a yeast infection, we treat you and we get rid of it. There are some women that have enough itching, enough discomfort because it's suppository that they have to stop it, but that's relatively uncommon. And related to this is the concept that recently a new technique has been developed involving vaginal progesterone. It used to be that all women took injections of progesterone after the embryo transfer and through almost the entire first trimester. But the new technique is that you take suppositories for 2 nights, and then on the 3rd night you take an injection. So there's a dramatic drop in the number of injections that you need to take once you become pregnant, and I like that. It's so much better for women, and there's no negative effect to it. So it's definitely something to consider when you do your cycle.